Carrot Corner, what are we talking about today?
The elbow. Medial epicondylitis, which is known as golfer's elbow, and lateral epicondylitis, which is known as tennis elbow.
Yep.
Medial epicondylitis, basically, your humerus has condyles.
So point to your medial epicondyle.
Medial epicondyle is going to be right in here.
Yeah.
And then we have lateral, which is furthest away from the body, which is out here. Mm-hmm. So anytime this epicondyle becomes inflamed, muscles attached here, specifically the flexor group, where when that gets inflamed, we get something called epicondylitis, which is inflammation. What causes this? Overuse of the muscles in the forearm, doing motions of flexions with bad form. So a lot of golfers and a lot of people that are basically putting a lot of emphasis coming in with the form of flexion.
Yeah.
A lot of times people will get like repetitive tears in that area because of all the use.
I even see this with a lot of my mechanics. That pronary teres, that muscle that runs right across the middle here that comes in and attaches there when they're doing a lot of the screwing and all that, just that repetitive motion. I get that a lot of my mechanics or any construction workers or anything along those lines. It doesn't affect a bunch of people, right?
Crazy. Less than 1% of the population have golfer's elbow.
Yeah.
It affects men and women between the ages 45 to 64. Women are more likely than men to develop golfer's elbow. Approximately 90% of the people with golfer's elbow develop it doing something other than playing sports.
Yeah, and that's just the day-to-day activity of just repetitive stress on that flexor group. The flexor group comes up here, flexes the wrist.
Flexors, extensors.
So that's where it's, a lot of those happen. Now, some symptoms that they usually get, I don't like I know everywhere you read online or anything like that, they say the numbing and tingling. Numbing and tingling is more of a symptom of the nerve involvement. So I don't like having that as a symptom to look out for this because it could be a plethora of other things.
I like more muscle-related symptoms.
Muscle-related. So more of the weakness, more of the tender to the touch. Like if you're pressing down on the table and it really hurts that medial aspect, it feels like a bruise. That's that inflammation of that epicondyle. Those are more or less symptoms that I like to sort of look for. And you could have, swelling of that area and it not be really golfer's elbow.
See, what I see a lot is a lot of people think golfer's elbow, but they're telling me, oh, it's shooting into my pinky and my ring finger, where that's always mistaken with the ulnar nerve. Yeah. Where ulnar nerve is being damaged, that's going to shoot to these three fingers right here. Yeah. Where, like you said, medial, we want to think muscle. We want to think aching. We don't want to think zinging, shooting.
Yeah, I don't want to think any of that. Numbing, tingling, I don't want to think any of that because that's all nerves more than anything.
Pain when you try to make a fist, decreased grip strength. That could also be neurogenic as well. Tingling in your hand, we're not getting into that.
Yeah, but sometimes when you weaken that grip strength, it's, is it weak because the pain's stopping you from being that strong with it? And that's why sometimes it's weak because, you have your, on the medial aspect is your strength, right?
Yeah.
Or I'm sorry, on the medial aspect, the ring,
flexion.
ring and pinky is more of your strength grip. So when you see that, you could see what that is. But to get into what you were talking about, median nerve and ulnar nerve, median nerve is more or less your thumb, index, middle, half of your ring. Other half lateral or medial half of your ring and pinky is more your ulnar nerve. So these are questions that we ask in history all the time because they could give us information without us even doing an exam, without us doing x-rays.
Yeah, we just know off the bat.
And we'll just, now we know our DDX could be anywhere from, C7, C8 nerve root or ulnar nerve or so on and so forth.
Yeah, you limit it and then you start trying different things.
And you start going in from there.
How do you treat medial epicondylitis?
Truthfully, man, I love ice baths. I love ice baths. Nice big pot of water with ice. Throw your whole arm in there. Let it sit in there for a good, 3 to 5 minutes. If numbness starts kicking in after 2 minutes, take it out. Don't wait the 3 to 5 minutes. Yeah. And just let that inflammation go away there. If that doesn't do the trick, then it's stuff that they could do at home, like, taking a tennis ball and rolling it up and down in this area. Not hard because you don't want to inflame it even more, but the fibers run this way. You want to sort of go cross fiber with it and go against the fibers just to get rid of all those knots and sort of tight muscles in that area. And then what are some other things? Brace, I believe, is one.
I believe it was a counterforce brace.
Yeah.
Basically something not along your fibers, but like you said, going in the opposite direction.
Yeah.
Where that's going to help a lot with the epicondyle.
Yeah.
Some people wear a night splint.
Yep.
Going to the chiro, doing PT.
So what would we do for them in the office?
bunch of things we can do specifically for inflammation. I like a lot of ice, obviously. I like cold laser therapy. Activate the muscles with like a TENS unit, something very low, not really aggressive.
Yeah,
where it's sparking the muscle up.
Yeah.
I wouldn't say adjust right away. Eventually start getting into there, see if there's restrictions in the elbow.
Yeah. I like ultrasound for this. Ultrasound and cold laser therapy, I think, are my two favorite. Because ultrasound, you could put it at that 50% and pump out information.
I love ultrasound. I just don't use it enough.
Yeah, I mean, it's just you could use it for either scar tissue and or inflammation.
Yeah, ultrasound's cool.
So I like ultrasound for this a lot. The thing with ultrasound is per area, every PT I talk to, it's 8 to 12 sessions before it just stops taking.
Some PTs don't like us, man.
I don't care who likes us.
Some PTs don't like us.
They drive me crazy, man.
I ran into this scenario.
What happened?
A PT told my patient, "You shouldn't be going to the chiropractor because your hips are misaligned." I'm like, "That's what we do."
That's what we do.
I'm like, "Oh, okay." And then like, I didn't even explain. I'm like, "Okay, when you want to come back, let me know."
No, and that's when you just gotta sort of explain of like, listen, if you're strengthening a muscle around an unstable spine or an unstable pelvis, you're just keeping it out of place further. It works together so well because when we're realigning and restabilizing the area and they're strengthening the muscles around it, well, now it's going to keep it into place longer. So that PT basically just wanted to be hero and tell the patient that they're just going to be the end all be all and fix everything. Whereas it would have worked so much more together.
So putting motion into things, I think chiropractic is the best for it.
Of course.
I think when it comes to stabilizing and rehab, I'll give PT the edge.
100%.
And this is us chiropractors saying this. But people don't recognize that. Yeah. Specifically like PTs, and I'm pretty sure there's chiros that think this as well, where it's like, we can work together and be very successful.
Yeah.
You don't have to isolate people and say, don't go here or don't go there. Integration, like we talked about a long time ago.
I had a 13-year-old come in today, that new patient that we had.
Yeah.
Okay. Broke his elbow falling off a trampoline when he was 4 years old. They had him casted for 6 weeks, never put him in PT. He can't supinate his hand at all. Like it literally gets stuck here. Okay, I believe it was left hand. So his right hand was going all the way around. Left hand was stuck here. If he wanted to supinate it more, he was literally turning his whole body to get it over. Okay, and yeah, I could help him with that. We could do cross-facial massage. We could do any type of scraping. We could do any type of cupping. We could do cold laser therapy. We could do manual manips. We could do exercises for that. But at the end of the day, I have 15 minutes with the kid.
Yeah.
PT has an hour allotted for, and they get compensated for that hour, right? Whereas if I'm spending an hour with him, I'm going to have to end up charging him for that.
You're doing it out of the goodness of your heart.
So I told him flat out, like, hey, truthfully, and I called the PT right there on the spot. I called him while he was in the room with us. Like, hey, I got this 14-year-old kid, 13-year-old kid, however old he was. This and this and this happened. And I sent him to OT instead of PT because OT is a little bit better for upper extremity and neck and facial stuff. So I sent him to OT instead. But they did better with them. They'll do better with them because they have more time to do it at that point.
Yeah,
so at
you can't be a hero. You're not going to do everything.
So, I mean, can I have? Yeah, I could have, but he probably would have got better going to an OT. And that's where it's just like not everybody sees that. And even with you, like I know I've been doing this for 11 years, 10 years, whatever it's been. And
I'm about a year and 2 months in, baby.
You just started hearing a lot of the PT saying don't go here, medical docs don't go there, whatever, right? And it's tiring because it's like you're explaining the same thing to so many different patients because they're all getting told this.
Problem is, I just feel like some professionals overtalk their patients. Like, I try to always bring the vocabulary down here where patients can understand. We're like, I had one patient come in and she was like, oh my God, I did my MRI and I have this. I have...
I mean, the way they word on MRIs is desiccation of the disc that's causing intervertebral
where it's like,
encroachment.
I told her all that.
But
obviously, I didn't use those terms. I said, oh, we have bulging of disc, L3, L4, L5. And like, I brought it here.
Yeah.
Where it's like, when you use desiccation and when you use like...
degenerative disc disease is another
all
one they
that
love.
Stuff,
Radiculopathy is another one they love.
That's terrifying.
Yeah. And, I don't like even saying disc bulge. It scares the crap out of them.
Yeah.
At the end of the day, I tell them, listen, this is where we found the pinched nerve. This is how it's getting pinched. This is how we need to fix it. And let's go from there. So then, and in my in the reports or histories that I give them, I always try to throw that terminology at them. And this just happened recently. I learned this over the years because what you're going through right now is the same thing that I went through. Yeah. So I started through my reports, started sort of telling them, hey, this is what we found. This is what the medical terminology is for. This is what I'm calling it. So if you hear these words, which they'll forget them, it's the same thing. Don't let it scare the living daylights out of you. So that's where it's just like, it's more communication and just nonstop communication at that point. It's tough, but you know, it's you're always battling, which is nuts.
For sure. I have a couple more things, but I'm going to go into lateral epicondylitis, and we'll have a little bit more of a discussion on this right after this.
Yeah.
So the cousin of medial epicondylitis is lateral epicondylitis, known as tennis elbow.
Yep.
I used to always remember this in school, the motion of it, like me pretending like I have a tennis racket and doing like a backspin.
Yeah.
Like I feel that on the lateral aspect of my elbow right away, like off the bat. So that's how I used to remember that.
Yeah.
Basically, it's the same thing in a sense, but different location. Instead of targeting the medial side, we're targeting the lateral side. And then this is extensors, muscles that help you extend. These muscles are taking a beating. So any motion that gives you extension of your forearm and your arm that you're doing wrong at times, or maybe not even doing it wrong, just doing it repetitive amounts of time. That's going to give you your lateral epicondylitis. Tennis elbow is an overuse injury that occurs when tendons become overloaded, leading to inflammation, degeneration, and potential tearing. It commonly affects tennis players who grip their rackets too tightly, and then basically extension is our corporate here.
Yeah. You know, and I think even when you work out triceps, right, and you're going too heavy, and you wake up the next morning and you can't fully extend your arm.
Talking about me?
No, just in general. Just in general. That's a form of that lateral epicondylitis, right? It's not fully inflamed, but you're getting the symptoms for that.
Yeah.
And you get the same type of symptoms where it's, you know, you're the weakened grip and the burning sensation and the tender to the touch, pain when twisting the arm or bending the arm. So the biggest thing there is just that extensor group, like what we were saying. And the treatments are about the same, right? We're changing the site of which we're doing the treatments, whether it's the ice bath or the ice massage. You know, I have a bunch of frozen styrofoam, halfway filled styrofoam cups that are frozen, and just do a little ice massage in that area. Yeah. Those are very good. Some other, you know, natural anti-inflammatory stuff that I love to put is arnica. It's a cream that you could get over the counter. Arnica is awesome, man, for any of that. I usually like to mix arnica and BioFreeze together. BioFreeze gives it that cooling icing factor. Arnica gives it that natural anti-inflammatory. So those are things that if you have these aches, it's better than any of, you know, the Icy Hots or the cayenne pepper or any of that, you know, whatever. I say cayenne pepper because that's all Icy Hot is cayenne pepper and a cream. So that's where you get that sensation of hot feeling, right?
How common is tennis elbow? Is it more common than?
I think it's a little bit more, if I remember correctly.
Yeah, between 1% to 3% of Americans get tennis elbow. It's more common in people ages 30 to 50. Affects all gender.
Yeah, I think it's a little bit more common just because the extension aspect of it, and you know what we're doing with our arms more often. They're not stuck in this flexion position, and we're not being forced in that flexion position.
The symptoms are pretty similar as well.
Yeah,
burning or pain on the outer elbow, pain when twisting or bending your arm, stiffness or pain. Swollen elbow joint, weakened grip. How do you treat this?
I'll do the same thing. Like I said, I'll do the ice bath. I'll do the Arnica and BioFreeze creams with the massage in there. I would do cross-friction massage along the extensor group. I'd actually work on the tricep muscle as well because those fibers come down attached to that lateral epicondyle. So yeah, I would you know, ultrasound, cold laser therapy. Those are all things that I would do in office.
I mean, we have a nice graphic here that we'll put up.
Yeah. So I was just sort of showing you where they are and what to do with it. And if it comes to the point where you're getting any type of tears or anything in there, you know, I'd look up the stem cell therapy. I'd look up PRP. I would try to go as natural with it as possible, truthfully, myself.
For sure.
Yeah.
Before we get into or would you rather,
I
want to talk a little bit about chiropractic. I was asked the other day, like, a patient has been to many chiropractors and said, like, why should I come to you? Why are you different? I told her, at our office, we treat chiropractic a little differently, where I feel like the general population is focused on snap, crackle, pop, goodbye,
come see you later, baby.
Never see you again. Where it's like we have a more of an approach of chiropractic is a lifestyle change. where it's like me cracking your neck right now or adjusting your neck. But General Pop is going to say cracking.
Yeah.
Me cracking your neck right now, telling you goodbye. Did we fix the issue?
No.
Sometimes I'm giving you a little bit of minimal relief. Sometimes I'm giving you a lot of relief.
Yeah.
Depends on the issue going on.
Yeah.
But the problem is with chiropractic, I'm not bashing anyone. I feel like so many people are just focused on pop, 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 goodbye, where we're not strengthening and we're not addressing the issue. And like we just incorporated like braces into our office, which is awesome.
Yeah.
Because the problem that we see majority of the time with people with upper back pain are your rhomboids, correct?
Yep.
So
Rhomboids and teres minor.
I always like to tell people, okay, rhomboids specifically, if they're super weak, what's going to happen? We're going to jolt forward. If we're super tight, we're going to jolt all the way back.
Yeah.
Where it's like,
Just very rarely we see super tight.
making sure your muscles are adequate for the situation is the number one thing. So chiropractic isn't whack, crack, and pop. I'll see you later. It should be, all right, we're going to fix this issue. First, what's going on?
Yeah.
We'll adjust if necessary.
Yep.
And we'll basically strengthen the area. That's why we're different.
Yeah. And listen, I think at the end of the day, too, like, you know, we try to incorporate everything that we got in our education to help patients.
Yeah.
Because at the end of the day, I mean, I think you and I both believe, and no matter what, results sell. Like, if you're not getting results, how good are you? You know what I'm saying? Like, what are you?
100%. Like, I was at the shop the other day, the car shop.
Yeah.
And some guy was telling me, oh, you're a chiropractor? He's like, that's temporary.
Yeah.
And I'm like,
because that's what he knows.
It's not, though.
It's not if you make it.
Who'd you go to?
Yeah.
You know? Where it's like, that hits home for me, you know?
Well, I always ask them, who'd you go to and what did you do after to maintain the progress?
And a lot of times it's nothing.
It's
it was
nothing.
Just pop, pop, pop,
it's
goodbye.
nothing. They don't do anything. Like I love the fact that we started incorporating the braces and
like I feel like it hurts the profession, man.
It does.
It kills
does, but
the
I feel like
profession.
every profession has that. I feel like every profession has that. You know what I'm saying? Like every profession has those couple of them there that are just so bad that they just ruin the name for all of them.
Yeah.
So I don't think it's just ours, but I think it's just a lot of ours has become more of a business aspect, like our profession, because, you know, their reimbursements got cut and they can't, you know, they have to see X amount of people to keep the doors open. So quality went down because quantity is staying, it has to be high to stay opened. So I think that plays a huge role in that. Whereas like, and then it just became part of the norm with them. Where it was just like, that's it. Even if reimbursements go up, well, they change the way that they are. Like now, like recently, a couple of laws have been passed where we could actually start, for some, we could start adjusting extremities, which we've been doing forever, but we never get reimbursed for them. But we could actually start getting reimbursed for them.
We just do it
right?
because they need it.
We just do it because they need it. Because if their ankle's off, if their hands off, if their knees off, well, we could adjust their freaking pelvis and spine until we're blue in the face. But if the main issue's in the ankle with the joint in the ankle,
you're not gonna fix anything.
Every time they walk, they're messing that up. So you got to treat the body as a whole and figure out where the primary issue is.
Unless
and go
you're
from
upper
there.
cervical doc.
Don't get me into that. Please. You're trying to get me in trouble, aren't you? You're trying to get me in trouble.
Just the atlas.